the guidelines and the committee's perspective, what are the most important updates that clinicians should know now about when initiating therapy for a new diagnosis of a PE in an adult patient?
First of all, anticoagulation is the mainstay. Of course, there are people in whom anticoagulation is contraindicated. If they're in category A or B and they're going to go home, you just start them on an oral anticoagulant. Everything's fine. And I would say the same thing with C1 and C2. If you're thinking about advanced therapies, possibly C3, certainly D and E, begin with a parenteral anticoagulant. We made a recommendation based on a review of the evidence in the literature. And we do recommend them, low molecular weight heparin. It's a much more steady state, much more, it's easier to use. And there's data to support that. For example, there's a meta-analysis that shows that low molecular weight heparin reduces VTE risk more effectively than unfractionated heparin without increasing major bleeding risk in patients with acute PE. So given its convenience, relative safety, and efficacy, we came down on the side of using low molecular weight heparin. And I think that will create discomfort for some people, but I'm hoping more and more folks adapt that.
And this is, we've already covered some huge points, but for everyone listening, a huge point. Guidelines are now recommending low molecular weight heparin in general for patients with new PE. And if you haven't been involved in a case where unfractionated heparin has been used and didn't get therapeutic quick enough, and I'll tell you, it's rough. I think there's a PE, they get started on heparin, but then something happens and you realize they weren't therapeutic in the first 6 hours, and everyone feels really terrible about that. So